name is Dr. Behnke, and I am a endocrinologist in the United States. It's early in the morning, so hopefully you can understand and hear me well. I am the section chief at the University of Virginia Tech University. This is my hospital, and I very much enjoy doing endocrinology here. I've been here just a few months, so it's a new job for me, but I thoroughly enjoy it. So what we're going to talk about today is several things. We're going to talk about the background of diabetes medications for non-diabetic conditions, and start with the original one, which was coronary artery disease, then go on to congestive heart failure, talk about renal failure, which is a new indication for these medications, and finally end up by talking about the indication for obesity and some of the new anti-diabetic medications. I have no financial disclosures, and pictures and copies are allowed. So the first study or look at non-diabetic indications for diabetic drugs was probably the Nissen and Kathy Wolowski study done in 2007, and this group looked at the effect of a drug for diabetes, rosiglitazone, and the effect of MI and cardiovascular causes. And what it was basically a meta-analysis looking at 42 trials, actually focusing on 3 or 4, that looked at the effect of rosiglitazone, a drug for diabetes, versus placebo. And when they did this meta-analysis, they found out that actually there was more MIs in the rosiglitazone group. There were also about 17 more deaths for cardiovascular causes in the rosiglitazone versus the control group. And even though those numbers are somewhat small, the odds ratio is 1.43 for MI and 1.64 for death. So this led the FDA to require all drugs for diabetes to have cardiovascular studies. And first couple studies were neutral, but then some drugs actually started to show a cardiovascular benefit. And the first of this was GLP-1 liraglutide, followed pretty quickly after that by the SGLT2 empagliflozin. So the first study, just real quick, I know I had a lot of time and I've started late, so I apologize for that, was the LEADER trial. The LEADER trial was daily liraglutide versus placebo, and you can see there was a difference in cardiovascular outcome, either cardiovascular death, non-fatal MI, non-fatal stroke, in these patients. First time that there was a benefit, a cardiovascular benefit for patients who had type 2 diabetes. The Empa study, the REG study, followed soon after Bernie Zinman's group, and again showed a benefit. And if you look at these two studies, LEADER's on the bottom and REG's on the top, you can see there was a difference not only in the primary outcome, but also in cardiovascular disease. And the thing that really kind of was striking, if you look at the Empa data, there was a 40% reduction in death from cardiovascular causes. So now you're getting pretty good data that patients who have diabetes can benefit not only from glucose control, but also from non-endocrine diagnosis cardiovascular disease by taking a drug that is primarily addressing diabetes. Now let's focus a little bit on the SGLT2s. You know, these drugs have many benefits. Of course, they cause decreased A1C, decreased insulin, decreased liver steatosis, of course, increased diuresis by the kidneys, increased lipolysis by the fat, but mostly the organ we're looking at is the heart. And the heart, because of the decreased preload, because of the decreased hypertrophy, decreased afterload, and vasodilation, has significant benefits, especially if you have a heart that's diseased by congestive heart failure. So the question is, can we use drugs, SGLT2 inhibitors, for heart failure even if they don't have diabetes? So look at the CHF, probably the first study looking at this, reported at ESC last year, was the Emperor Reduced. And the Emperor Reduced study was a study looking at about 3,730 patients, men and women with mild, moderate, and severe heart failure, either with or without diabetes, assigned to Empa or existing treatment. And just again, to go right to the data, I want to get an overview here. there was a benefit. You can see there was a 25% reduction in a combination of cardiovascular death or congestive heart failure in patients who are in Empa versus placebo. And I think this would be predicted from the previous study. However, when you look at this and took out patients that had type 2 diabetes, there was a benefit whether you did or did not have type 2 diabetes. So this drug is essentially beneficial for those who have CHF without diabetes. So this study was successful in its primary endpoint of cardiovascular death or heart failure, its secondary endpoint, which was total heart failure, and its third endpoint, they looked at kidney function, because we know these drugs not only preserve the heart, but are supposed, and there's some signal that there is a decrease in renal failure progression in these patients. And we'll talk about that later when we get to the kidney studies. So DAPA, gliflozin, did the same study, the DAPA HF study. Again, 4,000 patients, randomized 1-to-1, placebo or DAPA. And in this study, actually, the majority did not have diabetes. Only 45% did have type 2 diabetes. And what they showed was an increase in worsening CHF or cardiovascular death or death from any cause. So similar results to the Emperor study, 25% reduction in CHF or cardiovascular death in patients with or primarily without type 2 diabetes. So I think they've established pretty much these drugs can be used in patients who have CHF. And I mentioned it was a signal of beneficial for renal outcomes. Let's look at some of these studies in more detail about the renal outcomes. So DAPA-CKD was also presented at AASD 2020. And this was, again, very similar in design, about 4,000 patients, greater than 18 years old, either with or without diabetes. They did not have polycystic kidney disease, lupus nephritis, ANCA vasculitis, or type 1 diabetes, and randomized to DAPA 10 milligrams with or placebo. And the endpoint was a decrease in eGFR, progression in renal disease, or renal cardiovascular death. And you can see very significant 40% reduction in this endpoint. So these drugs do appear to have benefits for patients who have disease with or without type 2 diabetes. If you look at this as a subgroup analysis, you can see the data on the second panel. With diabetes, there was a reduction, but also without diabetes, there was a reduction. In fact, maybe even a little bit better. I also want to draw your attention to the last panel where you looked at patients either with GFR of 35 or less than 45. It seemed that both groups, even with the reduced ejection fraction, had a significant benefit of taking. Going back to the Emperor study, when we talked about Emperor study for CHF, we also saw a renal benefit, and here's the data for that in very similar numbers, 50% reduction, significant reduction in patients who had decreased renal failure or dialysis, patients with or without diabetes. DAPA study looked at heart failure outcomes to make sure that that was a factor, and saw a very good, robust reduction in heart failure death or heart failure hospitalization. So both of these studies showed benefit not only in the heart, but also in the kidneys. And finally, DAPA did look at mortality, and there was a significant and robust reduction in all-cause mortality in patients with or without diabetes. So this is kind of a busy slide, and I apologize for it. You might want to look at this later. But I just want to review that Jardiance and empagliflozin is indicated for diet and exercise in diabetes, in addition to diet and exercise for diabetes. It's also indicated to reduce cardiovascular death in patients with type 2 diabetes. Invokana, indicated for diabetes, indicated to reduce cardiovascular disease, but also indicated to reduce renal disease. And for our dapagliflozin, indicated for diabetes, indicated to reduce heart failure in patients with diabetes, but also indicated to reduce cardiovascular death and hospitalization heart failure in patients with heart failure without diabetes, and they approved and indicated to reduce the eGFR decline, end-stage kidney disease, or cardiovascular death in patients of renal failure without diabetes. So these drugs are approved and indicated for these conditions. A little bit about sotagliflozin. Sotagliflozin is available in Europe. It's not available in the United States, and it's a combination of SGLT2 and SGLT1 inhibition. SGLT2 is primarily in the kidney. SGLT1 is in the small intestines. And the two studies looking at that were the SCORED and the SOLOIST study looking at sotagliflozin for kidney disease, SCORED, CHF, SOLOIST. And if you look at the SCORED study, looking at cardiovascular death, heart failure, or urgent heart failure visit, again, 25% reduction in this primary endpoint with sotagliflozin. If you look at cardiovascular disease and take out CHF, you still saw a reduction in the sotagliflozin group. So it appears to be helpful not only in patients with CHF, but also in terms of cardiovascular disease, consistent with studies that we've seen previously. If you take the studies and combine them, and they had to do this because basically these studies were done during the pandemic, and so the enrollment wasn't as what they wanted, so they really had to pool the numbers to get the data. But when they did that, significant reduction in cardiovascular disease in patients on sotagliflozin, 30%, p-value is highly significant. One thing I want to point out about this study is they looked at patients who had reduced ejection fraction. And of course, there was a difference, there was a benefit. But they also looked at patients who have preserved ejection fraction. So these are patients with or without type 2 diabetes who had CHF with preserved ejection fraction. So this, diastolic dysfunction, the people we see that present with CHF and have a normal EF, and equally beneficial in this group. So it really didn't matter if your EF was preserved or reduced. You had a significant benefit. Let's switch a little bit and talk about incretins for obesity. We all know that incretins are helpful for type 2 diabetes, but now we have some newer indications. The FDA has approved the large dose, high dose of semaglutide 2.4 milligrams for the treatment of obesity and overweight. The trade name is Wegovy in the United States. And these are the results of the STEP trial, which looked at once weekly semaglutide at a higher dose. And we all use semaglutide 0.5 or 1 milligram for diabetes, but this is a 2.4 milligram shot given weekly and looking at weight loss. So you can see a very significant reduction in weight loss, 15-16% versus placebo in once weekly semaglutide. This slide shows, the comparison of semaglutide 2.4 milligrams versus 1.0 milligrams. And you can see that the A1C level was similar in the 1 or 2.4 milligram dose. But on the left slide, you can see there was a significant increased benefit of weight loss over 10% in the patients in the 2.4 milligram semaglutide. The drug is not indicated for diabetes, but it is indicated for weight loss, although it's definitely beneficial for patients with type 2 diabetes. Of course, you stop it, there's a reduction in the benefit, and actually there is a slow return to baseline. But this is the step 4 trial looking at 20 weeks of semaglutide. And then after over a year, the patients, of course, that continued the semaglutide did well, had 18% loss of body weight, significant. Those at placebo started trending back to normal, but even at a year, they had a 6% reduction overall in their body weight. So it does seem that even shorter term treatments are beneficial. So the superior of semaglutide 2.5 demonstrates that GLP segment is powerful treatment for obesity. And it's a great drug. There's a large patient-to-patient variability. About a third of patients lose 20% or more of weight loss. 10% exhibit more than 30% weight loss. And this is similar to the numbers we're going to get for bariatric surgery. There are 10% of patients without diabetes and 30% of patients with diabetes that don't respond and have a less than 5% weight loss. And so I think the lesson here is the drug really is mostly beneficial in patients who have obesity before they get diabetes. You really want to try to prevent diabetes if you can, and this drug definitely does lower body mass and decrease the rate of getting diabetes naturally. So like I said before, we're starting to get to a point where Instead of using older drugs like fenformin, we can use semaglutide, and there's some newer drugs of semaglutide plus carnitine, which are getting 25% weight loss, again, mimicking that of bariatric surgery. So I think the medical treatment of weight loss is going to be something that's going to be more and more available to our patients. I'm going to finish up with a sort of newer drug that's on the market. It's not available yet, but it's coming hopefully soon. It's a combination of a GLP-1 receptor agonist that we know of, where we know it works in the brain to increase satiety, it works in the stomach, it works in the liver. Combining that with GIP drugs that work in different areas in the brain, but also more likely to work in the subcutaneous fat or the skeletal muscle. And this dual GLP-GIP agonist, tirzepatide, has been shown to lower A1C in the SURPASS studies. So whether it's versus placebo in SURPASS-1 versus metformin in SURPASS-2 versus metformin or SGLT2 in SURPASS-3 or versus insulin in SURPASS-5, you can see the reduction in A1C is significant. And these are patients who have an A1C of about 8. They're getting into the 6s. So very robust value in terms of glucose lowering. But in addition, significant loss of weight. So we're talking 9, 10, 12 kilograms, whether it's and that's compared to not only placebo, but also SGLT2. You can see there's a significant reduction in weight. So this drug seems to be very effective in lowering weight and helping with glucose. So I'm trying to keep on schedule here, and I appreciate the organizers and giving me some grace here. The takeaways from this message are this. Number one, SGLT2 inhibitors can lower cardiovascular risk and renal failure risk. It's pretty much proven in many well-controlled studies. And they are indicated and approved for the treatment of CHF and renal disease with or without diabetes. There are many people that think that SGLT2 inhibition is actually going to help more for renal disease than ACE inhibition. So it is really a new tool you can have in your toolbox to help patients with renal failure prevent dialysis. The combination SGLT1 and 2 drug lowers cardiovascular risk, so that is something that you can also use. And weekly administered GLP-1 agonists can significant, we're talking 15 to 20%, and sustain weight loss, as well as the newer, and to be marketed hopefully soon, GLP-1 GLP agonists. These slides should be available to the presenter, and hopefully you can take a picture of them. These are all the references for the studies I have talked about. I will be around to answer questions, but I want to end to have time for the next presenter. You have a wonderful day in Cairo.